Sir, in case of transforaminal, sir, at the level of L5 and S1, sir, there are some challenges, I think, complications when comparing to the L3 and L4 doing. So, what are the challenges or complications at this level when doing the transforaminal endoscopy? So better go for an intralaminar approach for that level is. Another one, there is a in case of जैसे central और जैसे paracentral जैसे disc intrusion को जो पहले जो मैंने पूछा था क्वेश्चन एक क्वेश्चन पूछा था इंट्रालैमिनर और ट्रांसफोरल में कौन सा यूज करना है आपने बोला था बेटर वर.
Hello, Vedpal. Hello, Dr. Vedpal. This is Dr. Siraj here.
You are audible, sir.
Okay, just concentrate here on the MRI. Vedpal, can you see the MRI picture?
Yes, sir.
Okay.
Just zoom in a bit.
Yeah, यहाँ पे दिखाओ ये. So you can see this is a classical case of spinal canal stenosis, and you can see this canal is very narrow. There is a very severe hypertrophy, and I can see there some facet capsule also. So now he has more complaint. So like after walking for 100 to 150 meter, he feels he is becoming weak, and there is a slight instability on X-ray. So the idea is to just to do the decompression and see if in this particular case for me the facet is important. So you can see
Yes.
the facet is not completely vertically oriented. So I can just go inside and I can just remove this tissue, and so this will make the foramen bigger. I already explained him that since we are not removing the disc, so disc is again keep on providing the stability, but there are chances that in the degenerative process it will worsen the instability. So in that case we can do the fixation. But here the most important thing is if you do posterior decompression, and if the patient is improving, and instability is not worsening, and since we are not removing the disc, so disc is going to keep on going to provide the stability. So in most of the cases you don't need the fixation. So mild instability is not the ideal indication. So like there are 2-3 favoring point to me. The facet is not completely vertical, and the disc is not that bad, and the disc height is also good. So you can see the disc height is also good. So that way I can just start here and I can just do the decompression, and
Yes.
yeah, and most of the time it works. So this is a very good case where most of the surgeon will think about doing the fixation, but you see the fixation is having its own issues in terms of adjacent segment, and implant issues and implant failure. There are so many things. So now suppose if you just do the posterior decompression, and if the patient is fine, there is no need to go for the fixation. And see now even we do the fixation also with the olive technique. So like now the fixation is not also a big problem. So you can see this lateral canal is more important here, and I can see there is some of the facet capsule also. So this will look as the white structure while we do the endoscopy. So I'm going to use a special endoscope. This is like a 100 millimeter endoscope. Kishore, you want the things?
Which side we are going through, sir? Left or right?
Yeah. So initially he said that he had the complaint more on the left side, but
Okay.
now the symptoms are more on the right side. So like he has this both area is becoming numb, and more radicular component is more on the right side. Even
Yes.
I am convinced that on the right side there are more compression. So I'm going to go from the midline, and I will do both. So I will do like bilateral decompression. So I think it will just take a short time. So Vedpal, you can just explain that how we do the docking. So for the bilateral decompression, we'll be going more towards the midline, and for the
Yes.
unilateral decompression, we try to go more on the one side. And I can see the X-ray. So he has a good interlaminar window. So our bone work will not be too much, but yeah, this is a tight stenosis. This is a long-standing stenosis, and especially in stenosis, the long-standing vascular congestion is the reason the patients are more symptomatic while standing or walking for some more time. So that way, they have the problem. So you always expect a good amount of bleeding in case of the tight stenosis, because this vascular congestion will always correlate with the duration of the symptoms, and also the severity of the symptoms. So yeah, so like our target is to dock on the spinolaminar junction, and then we go and we will find out the age. We put the endoscope, so we will just ablate the tissue, and then we will find out the age. And once we see the age, then we will start the drilling, and drilling will do it till we find the age of the flavum. So then once we find the age of the flavum, so we will just try to expose the more and more flavum. So this will give us the exact idea how much bone work we need to do it, and then we use the Carison. So with the Carison we will have the control bone removal. So again the ligamentum flavum will give you the option how much to expose the bone, and then root and the dura, that will give you the idea that how much decompression is required. So that is ultimately plan. Again, there is no fixed thought process that how much drilling or how much. So like drilling till you expose the ligamentum flavum on the midline, on the lateral side, and on the inferior lamina. And how much to remove the ligamentum flavum, so till you are able to see the lateral margin of the root, that is your idea. Okay, so there is no fixed rule. Everybody asks the question, how much drilling. So no, drilling is there to reach the ligamentum flavum, and you see the ligamentum flavum in person, and then you just try to separate. So normally I don't like to do the interlaminar decompression. I will just expose the ligamentum flavum with the scissor or something. Then the ligamentum flavum which is attached with the bone, which is inside the bone, you will not be able to catch it. So ideal way is to remove the ligamentum flavum by completely detaching it from its uh, origin. Okay, so
Yes.
like you see, the patient is completely awake, and we'll just put the epidural. Okay, sure. Okay. Hmm. Hmm? Light चल रहा है, yeah.
There is sacralization on X-ray, I think, if you can see the X-ray.
Nah, I don't.
Not much. Yes.
No, it's not there, because I can see the transfer process is completely free.
पे भी भाई सेक्युलराइज्ड है थोड़ा सा.
But you see, in every of the patient, we always have to ask the one question to us, that why this patient develop this particular level stenosis. So there
Yes, sir.
has to be some ongoing pathology, ongoing micro instability. That's why this level is getting more stress, and that's why the ligamentum flavum has got hypertrophy.
Correct.
So always ask this question, that why this patient developed this. So that will give you the inside story, and at least we have to prevent those uh, ongoing issue. So that will help you a lot, because otherwise you just concentrate on the pathology. So like see that there are many, like I always see that the patient who are having the disc herniation, so either they have a past defect, or they have a sacralization, and sometime, most, not sometime, most of the time I see the patient come with MRI and everything, and basically they don't have any X-ray, and especially the dynamic X-rays are not there. So in one particular position, this the lytic listhesis will also not be seen, because you will see there is no defect. But when you just do it, when you just take the X-rays and everything, you will be able to find exactly where the problem is. So always try to find out the cause, that why this patient, suppose sometime the patient has some history of big weight lifting, so okay, that is the cause. Sometimes the patient has an accident, fall down, okay, that is the cause. So you always try to see that why this patient has the symptoms. सारे मत निकालो, सारे मत निकालो. मैं दे रहा हूँ ना, अमन खबर से. सपोज दूसरे सर्जरी करना होगा तो फिर नहीं रहेगा ना अपने पास, जो चाहिए वो निकालेंगे ना, इसके लिए तो ईटीओ है. So I am just utilizing the instrument which are absolutely required, because there is definitely no need to remove everything. ये दोनों दे दो, मैं बोलता हूँ. डायलेटर डायलेटर दिया वो 10 mm का. अब बाकी से चलो ओके. बस ये अभी निकालने की जरूरत नहीं है, चाहिए होगा तो मैं बोल दूंगा. क्यूरेट ले लिया ना. ओके, गिव मी स्पिरिट. चलो स्पिरिट दे दो. बस चलो. किशोर लोकल ले लो. डाउन है ना. चलो एक्सरे में कौन है? somebody come for the x-ray. सर ये पीछे बांधे. सर ये पीछे कर. चल लोकल ले लो. ढीला गया, ढीला गया. आरएफ प्रोब ले लो. ये बड़े वाला प्रोब है. नहीं 7.1 है. 7.1.
हम 10 मिलीमीटर वाला स्कोप यूज कर रहे हैं। हम्म। वो जो निकलेगा वो लोकली चल मिल लो फिर। नहीं नहीं वो सब कर लेगा कुछ पर। चलो ओके, एक्सरे कौन दे रहा है? So Vedpal, I'm using this 10 millimeter scope, which is
Yes, sir.
having a 7.1 millimeter working channel. So
16.
yeah, so I can use this interlaminar probe also, so I will be faster. So I have both the scope, but I will use 10 millimeter. ओके
Yes,
चलो,
sir.
नहीं कुछ भी नहीं करना है भैया, कुछ भी नहीं करना है, बस बताओ। पिक्चर थोड़ा नीचे ले लो, आपने वो घुमा दिया इसको। पिक्चर बस। Okay, so Dr. Vedpal, you can see this is our X-ray दिखाओ X-ray. This is our going to be the entry point. Yes. Picture. Picture. Okay, so Vedpal, you can see
Sir.
this is my entry point. एक सुई लगेगा, हाँ? Okay. एक छोटा सा सुई लगेगा. So we are just starting. So I am just putting the needle. So you can see I am quite close to the midline. Picture. X-ray. ठीक है. अभी टेबल अप करो. आई फ्लूइड थोड़ा स्लो कर दो. आई फ्लूइड ज़्यादा दोगे भी ना, बिकॉज कैथेटर हमने नहीं रखा. सो यू सी आई एम आस्किंग द एनेस्थेटिस्ट नॉट टू यूज द आईवी फ्लूइड अ लॉट, बिकॉज we don't want
Overload.
yeah and we don't want to use the catheter. So
Yes, sir.
so after the surgery patient can just go by himself. Picture. So now you can see this is the area where I have done the infiltration, and now take the lateral. Wait, chalo, wait. I'll just go with the spinal needle. I can touch the bone. Picture. Okay, fine. यहाँ पे किसका फेस आ रहा है? वो हाँ चलो, एक मिनट, एक रुको. So I am already touching the bone here. So you see, when you infiltrate the skin and the tissue up to the lamina, then you don't need to do a lot of that is the way you can do it under local. थोड़ा बढ़ाओ, चलो. So here you can see that we are at the lamina, right? Okay, Vedpal, I can feel the
Yes,
bone.
sir.
I can feel the bone here also. किशन लोकल दूसरा दे दो. ये 5 है ना? 5. So at least you should be in the line of this space. Okay, Kishore, knife. So now I'll just take a small knife and make a stab. थोड़ा है ना, बाद में इनका हेड अप कर देना. So this is for the fluid. थोड़ा पता चलेगा. So whenever you make a stab incision, sometimes you feel pain because that may not be covered fully. So you always inform. So at least they don't have unexpected pain. So you see now I'm already docked here. Okay, so you see now I can just change my scope. So you can now you can see I am on the line of the picture. Sure. ठीक है.
Yes, sir.
So now I'm putting the cannula and then picture. So here you see this is a very yeah, now you take the AP. So this lateral picture is very important because this will give you the rough idea about the depth of the lamina, thickness of the lamina. AP ले लो, AP ले लो, चलो AP ले लो, AP ले लो. So this will give you the exact idea about the thickness of the lamina. So when you are working you should be knowing that okay, what exactly, how much you are supposed to drill. Okay, so you should be able to get the idea before you go for the surgery, so you know that okay, this much is thickness is required. Okay, now you see, so now here uh, okay, show me the picture. बस बता, एक बार बता दो, लास्ट बता दो. Okay, so now you see, now I know, okay, this way picture, this way I am at the edge of lamina, so I should know that this picture, यहाँ पर बताओ, you see Vetal, this is very important.
Yes,
I
sir.
will be checking here that this way I am at the edge of lamina, so my entire surgery I don't need to keep on taking the x-ray, where am I, I know that okay, you can see on the x-ray we are on the edge of the lamina. Okay, so now I will drill and see, I have deliberately take the incision little above because most of the time you have to do more work on the upper lamina. So that's why now I have started taking 1 or 1.5 centimeter little above the incision, so that helps me to work better. So this is a new development, Vetpal.
Yes, sir.
Yeah. So previously we were just on the edge, then I have to work with my scope like this. But now we work like this.
Yeah.
ये सब उधर ही रखो, ये पानी आएगा खराब हो जाएगी. मैं बोलूँगा ये तब करेगा. Fine. ठीक है. चल. Okay, so up you can go. Okay, इनको इनको है ना 50 मिलीग्राम, सुनिए, 50 फेंटानिल दीजिए, 2 मिलीग्राम मिडाजोलम दीजिए, लेट ही मेक कंफर्टेबल. इनको 50 से 100 फेंटानिल दे दीजिए और एक है ना ऑक्सीजन का वो रख ही दीजिए, नेचुरल प्रॉम तो रख ही दीजिए. ठीक है, 14 दिया था, ठीक है. हाँ तो सो जाएंगे. हाँ तो और मिटा दे दो. मुझे थोड़ा ब्लड प्रेशर है ना अराउंड 160 चाहिए. हाँ नीचे कर दो, जितना हो सके इतना नीचे कर दो, कर दो कर दो कर दो कर दो. फाइन, फैंटास्टिक फैंटास्टिक. चलो. हाँ ये बढ़िया है ना, कंफर्टेबल. ये ज़्यादा बढ़िया, मैं ऊपर चढ़ के करूँ इससे ज़्यादा ये कंफर्टेबल है. तो नाउ वेदपाल यू कैन सी द कैमरा पिक्चर.
Yes.
Okay, so now you see I'm just putting the white balance. Okay, okay, so you see these are all the preparation. We are just you can see this is the irrigation. So like I don't want to the fluid to fall on me, so we have put the this extension, and this is a special drape for. क्या हो गया उसमें एड्रेनालिन डाला, दोनों में एक एमएल एड्रेनालिन डालो. एडिया दे दो, चलो फटाफट. हाँ, and see we are asking to do the head up, so this head up will prevent नहीं, पूरा ऐसे करो टेबल. ठीक है, चलो अभी ठीक है. चलो फाइन. ओके, सो नाउ ओके, चलो आरएफ दे दो किशोर. आरएफ चालू किया. थोड़ा पावर ज़्यादा रखना, मैं बोलूँगा तब. Okay, so Vedpal, can you see the camera picture? Give me 4 seconds.
अभी आउटसाइड पिक्चर दिख रही है सर, बट इट वाज विजिबल.
कैमरा पिक्चर दिखाओ.
कैमरा पिक्चर प्लीज.
कैमरा पिक्चर दिखाओ, और देखो एक यहाँ पिक्चर दिखाओ और एक वीडियो पिक्चर दिखाओ, ठीक है. सो वेदपाल,
अभी पिक्चर दिख रही है, इसको छोटा कर देंगे, कैमरा पिक्चर दिखाएंगे. हाँ अब ठीक है,
हाँ ठीक है.
कैमरा पिक्चर इज विजिबल
So,
नाउ.
so now first step is to confirm where exactly your bone is. So I'm just holding it and I'm confirming it. Okay, मुझे bone feel होना चाहिए, उसके बाद ही मैं कुछ भी आगे काम करूँगा.
यस सर.
Okay, this is extremely important before you touch any tissue, because otherwise what will happen कि आपका incision थोड़ा आगे पीछे हो गया और आपको नीचे bone का support नहीं है, then you can be anywhere. So always try to feel the bone first.
कैमरा पिक्चर इज नॉट विजिबल.
वो वहीं से कर देंगे, वहाँ पे जो बैठे हैं ना वो उनके हाथ में है अभी. Give me this RF. So now Vedpal, the most important here, not to touch this tissue with the forceps. I just remove some blood clot. Now RF. So I'm just doing the RF just to cauterize the tissue. So here for this particular step, I prefer 0° RF because that will go directly over the lamina. Okay.
यस सर.
So like see, this is like like this is people used to use for the biportal surgery, and this biportal surgery was used for arthroscopic surgery, so they are using the same vein. But here the tissue, I am more interested working the tissue here, not on the side. Okay, so because that will only expose the lamina. Okay, so yeah, see, once I expose the lamina, then if I want to work in the periphery, this probe is useful, but it's okay. So you can see I'm just cauterizing the tissue, so like my visualization will become more and more good, and I'll be able to do it in a better way. But you see now all this process, docking and everything, the patient is quite comfortable. So that you can convince that this is possible under local anesthesia. Wait, see, my reason for the obsession of for using the local anesthesia is when the patient is awake. So we say that your awake patient is the best neurological monitor. You can get all the feedback. Patient can tell you something. Okay. So now suppose if we have anesthetized patient, so important, the patient will not be able to report you any complication, or like mostly because of the fluid they may have a neck pain or something, and then anesthesia just masks this, they don't prevent it, and so that is the way you have a problem. So we always want the awake patient. So you can see I'm just trying to cauterize more and more tissue. Fine, this is a maximum setting. Fine, no problem. ठीक. This was a, yeah. So you see your chance of damaging the scope is also high with this side probe, because by chance if you just take it out, you will just hand it on the lens.
Lens, yes.
Yeah. So again, like 0° probe is better here. Wait. Okay, forceps. So you see again I will just expose the bone here.
Yes.
So you see the bone is just below this. So if I have a 0° probe, it will just burn out this one and it will expose the bone. Simple probe le lo, curve wala. So normally you know Vedpal, I always use 2 probe at a time. So,
yes sir.
So one probe is for working to expose the lamina, and then RF, and the one probe is to work on the periphery. So now I can feel this is the facet here. So again, like if I want to remove this tissue, I will just do it, expose the bone, I will cauterize it, and then I will do it. So it will not bleed. Otherwise, what will happen if you just catch this tissue, and if you just try to burn it or pull it out, you will have a lot of bleeding. Wait. So I'm just trying to go more inside, and I can see forceps the forceps. So this portion is a lamina. So you see now removing the tissue is not a problem for me, and you can see this is a lamina, you can see this is a fat. So now I can do this. So I will just feel it. So again, give me the RF. So you can see with this direct probe, my exposure is faster, because I can just touch here, I can expose it, because the lamina is front of you. Okay, you can see this tissue. So this cannot be done with the 90-degree probe. 90-degree probe is good for here, this tissue, side tissue on the periphery,
Yeah.
but not here. So now you see I feel the bone, then I check it, I check it, I check it. So I will just find out the edge. So you see this is the bone and this is not the bone. So then I have to start drilling here. So the idea is to find out the edge of the bone. Okay, so this is the edge of the bone. So this is my tactile feeling. I am just feeling it, the bone. So I want to be very sure that where is the edge, and then I can start drilling. Okay, fine. Okay, now I will just go inside and I will just start drilling here. So I'm just getting the tissue retracted. So I'm using this 3.7 3.8 millimeter burr. So like see, always I feel the bone here, and then you see this is the edge. Okay, drill. So you see this is the burr, you have to hold it in a special way. So my right hand is just pushing the burr up and down, my ring finger is holding the burr, so it will prevent any slippage of the burr, and my left hand will help me to go inside. So like the position change of the position of the burr is determined by the left hand. Wait, so you can see now this is the area where we are burring.
Yes, sir. This is the lamina,
Yeah.
upper lamina, I think.
So let me just remove this tissue so the picture will become more clear. Yeah, give me RF. I will try to shrink it with the RF, or I will use the forceps. So always try to be the picture more and more clear, so you will be having exact idea where you are working. So you can see now the bone more clear. So this is the bone and this is the junction. Okay. Fine. Okay. So now you can see that we are more and more clear. Now I will again use the burr. So you see the RF requirement is quite, you don't need RF for very long requirement. So now this drilling the lamina. So what I am doing, just making the lamina more slopey, so my Carrison can hold it, and I'm just trying to find out the edge of the lamina, final part of the lamina, where I can just go and I can just take out. So this inverted V should always be at a 6 o'clock position. That is your orientation.
Yeah, listen.
Sir, give me one gloves on my finger. No, you continue it. Close on my index finger. Okay, so now Vedpal again, give me RF. Goes there, goes. I'll just. So you see this with this index finger, can you see my the way of holding the scope?
Yes, sir.
So you see this index finger is pushing the sleeve to the bone. See, because of the elasticity of the tissue, this sleeve will always come out. So I have to keep on applying the pressure on my index finger. So I was
Mhm.
feeling a little painful uh, because it was coming out. So you see, this is the way I'm holding the scope. Again, just see,
Yes, sir.
wait. See the picture. This is my two last middle finger and my ring.
Yes.
They are on the skin. My index finger, my this middle finger is encircling the sleeve. This finger is on the top of the sleeve, so it is
Mhm.
pushing the sleeve to inside. And this my thumb. Thumb is helping me to get the scope. So it is
Lift the scope. Yes.
up and
Up, down.
down and whatever. Okay. So this is the way you hold the scope. And I tell you again, for when you start it, it's not easy because your those muscles are not trained, so you will feel a lot of, and you will feel
Tired.
like a
Yes.
little cramping like sensation. So once you do it, so now you see I'm just trying to uh, make this area more and more clean, so you will be able to see the picture more clear, and then you can just do it. Okay, so here also you can see. Fine. So now wait. So now you can see this is the part of the lamina. Give me drill. We have already drilled. So I will just drill it little bit more. So I will find out the last edge of the lamina. Then we will start working with the addition. Drill. So you can see we are using the diamond burr. So this diamond tip is having the very good advantage. It will turn the bone into the powder. And
Yes.
see, with the drill we are using the side of the drill. We are not using the tip. Okay, so like this is a controlled drilling and always under vision. So now you can see I'm drilling more. I'm just trying to find out the last part of the lamina. So I will just start using my Carrison. This is I'm going toward the midline. So this is like this process here. So this lamina also with the endoscope you can find out that it is having the outer layer is yellow cortical bone. The inner is more pinkish and the most inner wet is also whitish. So when I get, you see this is the picture you see. The outer part, this is outer part of the lamina. This is the pale white. Inside you can see the pinkish, and then you go deep down, it will also the pale white. So that is a cortical bone.
Yes,
Drill,
sir.
drill. So you can see with the endoscope you can get a view, and you can see the bleeding and everything is quite controlled.
Yes.
So your job is quite easy. Wait. Now again, what you need to do is this. This is the superficial phlegm. So I just need to shrink it again. So you will be see. So you see, I am not worried about any tissue here. That I will take
Ye-
care later. I don't waste my time to
Yes,
take care
sir.
about the tissue over here or here because my I just need to do something, so it will expose the ligamentum flavum, and then this will whole will come out. So you don't need to waste your time here. You just focus on the area where you want to work. Fine. Okay, now I will still use the drill a bit so I can go more inside. So now I will start drilling more onto the midline side because this patient we want to do the bilateral decompression. Drill. So now you can see I am able to find out the last part of the drill. So the quality about this drill, wait, you can see the drill is not doing any effect to the soft tissue. It works only on the bone.
On the bone, yes, sir.
Yeah. So this is a very good advantage. Drill. So now this is the upper lamina, this is the middle part, and this is inside. Okay. So I will have to still work here. So, so you see from the drilling also you can make about the quality of the bone. So this is a good quality of the bone, what I can feel with myself. Wait. So now you see we are still going more and more inside. I will still use the RF. So I will just shrink the tissue. So you see I'm always trying to keep my eye on the uh, edge of the
Lamina, yes, sir.
phlegm and lamina. So once again if I shrink it, then only I will be able to see the edge here. Okay.
Yes, sir.
So this way you can make it more and more clear. Fine. Wait. Now you see I know that I have reached to the curate, the last part of the lamina. So I'll just show you, but I still need to do some of the bone work, because like I want to do all the bone work once in all, and then I don't want to do it. So like you see this is the last part of the lamina, you can see. So with this
Yes,
curate
sir.
I can,
Curate is going underneath the lamina.
yeah, so I can detach some part of the phlegm. Okay, irrigation. So whenever you see something like this, so the irrigation is a problem, so close the second one and just replace with another one. Yeah, no, I want drill. First give me RF, then I need a drill. So you see you have work up to the full depth of the lamina, but I again want to expose this more area, because we want to do the bilateral decompression. So this part will also require. Okay, so this is the midline. So 12 o'clock is midline, 6 o'clock
Yes, sir.
toward the 3 o'clock is superior lamina, and this is toward the inferior lamina.
Yes, sir.
Okay, fine. Drill. So now you see, Vedpal, I am going more towards the midline. So this is called the over the top bilateral decompression. So I will just do my body work. So you can see the good quality drill is the key.
Yes.
Okay, and like see what you need it. Yeah, there are some other options, but they are not as good as this particular drill, because this will do your job nicely. Wait, otherwise if you keep on taking a lot of time in drilling, so then your surgery will take time, and then you will not be happy. And most important for me is when I do most of my surgery under local anesthesia, so I have to be really fast.
Quick. Yes, sir.
So I just like keep everything ready, because you see after some time I know my patient will not be able to be comfortable lying prone, and then if they have some fluid related issues, they will be mad. So either you have to stop surgery or you have to cancel it. Wait. So better is to use the good stuff, so your job will be
Faster.
faster. Yeah,
Yes.
yeah. So you see, I always say that, like, see, suppose if you are a neurosurgeon and you are operating the brain tumor, you need a good microscope. Now you compromise into that, you are into trouble, and it will affect your outcome, and it will affect even your further practice also, because
Yes, sir.
your surgical outcome are your success. Yeah. Wait. Fine. Okay. Give me drill. So I will again drill little bit more toward the midline, so then I don't need to work again and again. Drill. Wait. Okay. Now give me Garrison. And give me first curate. So you see now I will just try to expose the ligamentum flavum more and more. So if I am able to expose a good ligamentum flavum, then rest of the things I will be able to do with the. So you can see this I am beneath the lamina thrown. So I am using the 3 size Garrison. So you can see. So let's see. This is how I can do the bone work. So here the patient's blood pressure is also very important. If there is a ooze, so like I always ask the anesthetist to use the labetalol, so at least my field will be more clear and I will be able to do the surgery faster. So now you can see this is the ligamentum flavum here.
Yes, sir.
So this ligamentum flavum is my guide. Okay. So like the question of how much to remove the bone. So till you find the edge of the ligamentum flavum. What's happening? C4 4 से करके साथ में. So you can see ligamentum flavum now.
Yes, sir.
So now you see when you get the edge of the bone, so this is your guide. So you know, okay, where you go, where you go, where you go. Okay. So now to faster my work, I use the 4 millimeter Garrison. So it will help me to work faster. Yeah, this yellow part is a flavor. So now you have some oozing. Okay, just reduce the setting, uh, RF setting. 3 कर दो. So now you see this is a small oozing here, so I'll just try to control. So Vedpal, in my experience, like we have 2 scope, one is 5.7 working channel, one is 7.1 working channel. So the 7.1 is good when you have the tight stenosis because it provides a good outflow.
Yes, sir.
So your field is more clear with the bigger size scope. And
Okay.
yeah, so little bit your bony work will be more because when you want to do the over the top decompression, but that is okay. But because you see for this particular cases you need to do the good decompression and the bleeding is really a trouble. So you see that's why I take my time just to work on this thing. Fine. So now you can see the ligamentum inside nicely.
Yes, sir. Very well.
Okay, so you see we are not concentrating on any of the tissue which is above. For just target and our eye is on this area. So now you see this is I am going to the opposite side. You can see. So this is I am in the midline.
Yes, sir.
And I am just trying to work here, so I will be able to expose this area also. So थोड़ा blood pressure थोड़ा करो labetalol दो 3 आपने 3. So you can see that there is a lot of bone oozing. So this
Yes, sir.
bone oozing is also related to osteoporosis and old age. So now you see this is I'm in the midline. Okay. Now I just want to see the below, so I will just remove this tissue because this is hindering my view for the opposite side. Okay, Carissa. So now you see I will just come on this side. this is toward the facet. So you can see I'm below the facet, and then I'm working on this. So I will not do much of the lateral work because I know that this is a little unstable spine. So ना एडीआर डाला है आपने, दोनों में होना चाहिए. Every point should have one ADR. ये जो oozing है ना, see Dr. Vedpal, this oozing will only be controlled with the adrenaline.
Yeah. Yes, sir.
So using the adrenaline is good, always good. So now you see I am able to remove this ligamentum flavum from here.
Yes, sir.
Let me just do it from here. So you can see also, like I am able to work on this area. So I am able to detach the ligamentum flavum here also. So now you can see the ligamentum flavum is almost over.
Yes, sir. Edge of the dura should be visible.
Okay. So here, if you see the MRI closely, this ligamentum flavum hypertrophy there is not more into the center. The center is always free. It's more into the lateral aspect. So I always say that pathology of stenosis lies into the lateral canal and in the foramen area.
Yes, sir.
Okay. So now you see there is a good amount of oozing. So what I'm going to use is I'm going to use a cap. So Vedpal, you can see this is a cap I'm using. So the cap will provide a kind of a positive seal. So you can see my picture has become better. So now I'm not going to chase these bleeders. I will ask the anesthetist to reduce the blood pressure to keep the systolic around 100. So they can use the labetalol. That is the best medicine for this particular thing. So now you see this is our end point of our bone dissection. Okay, because now you see the ligamentum flavum is detached here. So I will just make it little more free, and then you will be able to see the canal inside. You will see the epidural fat inside. So you see now. So this is our end point. Okay.
Yes, sir.
So this is what we wanted to achieve. We wanted to remove the ligamentum flavum. So now this is on the opposite side. So let me just try to do whatever the bone work I can finish it. I will finish it. So it will help me to do the opposite side work also. I don't use any 90-degree carison. I use always 45-degree carison. Now give me curate. So now Vedpal, I will use this curate just to expose this one.
Ligamentum flavum to be removed with the curate?
Yes. So now you can see I am going inside.
Yes, sir.
Okay. Now you can see that my curate is just, I am just rotating the curate. So
Yes, sir.
this is just to go below the ligamentum flavum, and then you can just do it. So now here somebody is asking me the question when you use the 45-degree and when you use the 90-degree carison. So you see it's more difficult here to expose this curate, like expose to catch hold of this bone. So if you have this 45-degree, it can slide inside. Now for the 90-degree, you have to go in, and then you have to go like this. Okay, RF. So now you can see the nicely ligamentum flavum here. This tissue is coming in between, so I just want to shrink it here. So my picture will be more clear. So I still need some drill to work on this part of the bone, because I want to expose this part of the lamina, this part of the ligament. Fine. Fine. So you see, I already expected a good amount of bleeding because of nature of the stenosis. So it was a very old stenosis. So that's why I'm going little slowly, and I'm just trying to work in a way that we will do it slowly, because if I keep on chasing this bleeding, I'm not going to succeed, and it will just increase my surgical time without getting the control of the bleeding. Wait. So now give me drill. So you see, when I put this one, so I'm just trying to drill somewhat over here, so I'll be able to take out this ligamentum flavum, because this is a vertical lamina. So vertical lamina, I cannot remove it with my Kerrison. So again, I'm making the lamina more slopey. Hmm. So see, since I have the protection of ligamentum flavum, so I'm not worried. So that's why I didn't remove the ligamentum flavum before I finished my bone work, because ligamentum flavum is my protection for my burr.
Yes, sir.
And see, whenever I want to see the structure, so what I do, I obliterate this outflow. So you can see, you just increase the pressure above the venous pressure, then you can see the structures nicely. So you can see now this is the last part of the ligamentum flavum. I
Yes, sir.
just want to burr somewhat over here, drill. So you have to burr from the top, from the up. Wait. Okay, so now I will remove this part of the bone. So you can see I have this option to give me Kerrison. Not 3. So again, here also I am just trying to find out the edge of the ligamentum flavum. I don't want to stretch it. I want to remove it completely. So now you see, with this I can take out the bone, because this pitch of this Kerrison was not is not so big, because it's endoscopic Kerrison. So what I want to do, you see, I drill it, and now I go inside, and now you see I can work with the Kerrison. You can see now you can see the extension of the flavum inside. You can see.
Yes.
So
Yes.
I want to completely expose it rather than just pushing it. Okay, so that my detachment will be more safe. So you see, I can come here, and then you can remove it. Okay. Hmm? No, this is ipsilateral ना, हम contralateral गए नहीं अभी तक. You can see the position of my scope. So now you can see the nice exposure of the ligamentum flavum on one side.
Yes, sir.
So this is what actually I wanted to achieve. So I still want to go more laterally. So you see, without removing this bone, you cannot achieve the complete. So you see, some of the people, they will just remove the flavum in between, and then they say the surgery is finished. The patient will not improve, because this is the main area where there is a compression. अभी एक साइड का तो करें, पहले एक साइड का करेंगे उसके बाद दूसरा करेंगे। पहले एक साइड का हो जाए ना, उसके बाद दूसरी साइड का करेंगे। So now you see I am coming more and more lateral. So this is a lateral facet. This is I am working on the IAP. So again you see whenever I want to see the nice view, so I will just obliterate and I will just check it. So you can see. So even I can see from where the bleeding is happening. You can see here. This is
Yes, sir.
so this is also the bone oozing. Most likely it will not cover with the RF. So I will use the bone pressure with the kerosene or curate. So let me first try with the RF. So you see how you do is you go to the bleeder, touch it. So if it stops the bleeding, it means you are there, and then you do the RF. Give me kerosene, round kerosene data. So you see this is a significant oozing. So this is not round, right? Round, round. Number. So this is I am going to apply the pressure through the kerosene, and again I will see the blood pressure. So you can see the bleeder. I will just press it. ओके दोनों चालू कर दो, दोनों फुल कर दो, चालू। हाँ और दूसरा है ना, ये दो पॉइंट यहाँ पे लगा के रखो, तो तुरंत खाली हो जाए तो दूसरा लगा देना, और उसमें एडीआर भी लगा के रखो। So now you see we have almost
It is opening from the bone, I think.
yeah it's a bone ooze, definitely.
Yes.
You can see here 2 millimeter आपने। So sometime what you can do is also you can go below and then take out this chip of bone. That will also control the bleeding, and then keep it pressed for some time. So like you see, I'm below and then I hold it like this. So you see, Vedpal, this is the tissue which I was talking about in the MRI.
Yes, sir.
Yeah. So it's a white tissue. Okay.
Yes, sir.
So this I was expecting close to the facet. So you see, you really need a good RF here. So like you see,
Yes, sir.
there are two kind of cautery machine. So one is a plasma and one is a radio frequency. So the plasma is quite powerful. So I always have a big fear that with the plasma you can actually create more thermal lesion of the neural structure. So here,
Yes, sir.
if you have the 4 megahertz RF, which is more safe here. RF. RF. What? Okay, wait. इसकी आवाज़ बढ़ाओ, RF की आवाज़ बढ़ाओ, वॉल्यूम बढ़ाओ. So you see, like I was not able to hear the sound, so I asked them to increase the sound. Fine, okay, fine. RF. Yes, yes. You see, I should be able to see where it's working. So I was not very sure. Yeah, now I can hear the voice. Because you see, normally I don't keep this control with me. I always give it to my assistant. I'm just focusing on my endoscope, so I don't want to change my position. So now you see, I'm not going to change this oozing. I'm just going to start now concentrate over here, removing the ligamentum flavum.
Yes, sir.
Okay, because you see, this is a bone oozing, and once the venous pressure will go down, it will drastically reduce. So use the laboratory because now the blood pressure is 136. लेवल है यहाँ पे. And you can see Dr. Anupam is talking to the patient.
Yes, sir.
So that is a beauty.
Yeah.
So now you see this is the one side of the ligament flavum. You can see the nicely sheet of the flavum. There's a oozing here. So I just change my concentration here. Let me see. दूसरा लगा दिया ना, दूसरा भी. I know to stop because then the congestion will relieved. अच्छा, inform him. डॉक्टर अनुपम इनको बताइए कुछ आएगा. So if it is too much, now you see I'm below the phlegm.
Yes, sir.
And now I'm detaching the phlegm like this. Okay. So even like if you want, you can see the tip of your curate also. So my traction is on the upward direction. So
Yes, sir.
this is
Lifting it.
Yeah, actually I'm lifting it. Yes. So that is a safety. And you see this the fluid here. I see the best advantage of using the fluid here because this fluid will go inside. So actually this will make a plane between phlegm and dura. So no, give me curate. So this will actually keep the dura down.
Yes, sir.
So that way you have the option to lift it. So once you remove the phlegm or once you detach it, your job is done. So you can see. Okay. Now give me kerosene. So now you see curate is a smaller diameter. So with the curate, I'm not getting the good control of the bleeding. So I will use the kerosene.
Harrison. Also.
As soon as I put the kerosene, my picture will become more clear because kerosene will provide the good seal. So in fact, we have designed these instruments according to the diameter of the scope. So you see the thinner kerosene are not useful to control the bleeding. Huh? थोड़ी बढ़ा दो. So you see this is the oozing is coming from all the bony surface, but like it's okay. I can just now put the kerosene here, and I just want to remove this kerosene. Two chair. So now you see here. So now I'm holding the bigger part of this one. See, I can always change my scope to this direction, so I can see that I'm not putting the dura or something. Okay, and you can see this is a quite tight. So I'm just trying to hold it. nicely. Okay. So now this is, now you see, now you have the advantage. In upper part you already have detached the phlegm. So now you go in the lower part, you go like this, you go like this, you go like this, and then you remove it. So you will be able, because on the upper part you already have removed it, so now it will be just free. Now you see, you can't use the 90-degree here. Okay, the 90-degree will
Yes.
not slip inside. And you see, like we are not obsessed with removing the end block or something. We just try to work. Give me 2 mm. So just try to remove slowly, slowly. So you will be able to see that, okay, you are just decompressing, you are decompressing nicely. So you see, this is a superficial phlegm, this is the deep phlegm. So I will go here, now I will work here. Okay. So this is the way I am just opening the canal nicely. Now you see the hell of a congestion. You can see the epidural pulsation.
Yes, sir.
So this is the reason for his like a severe complaints, because he has a, and see now Vedpal, the
Yes, sir.
bleeder which we were fighting, now it's not seen. So it's like those bleeder will come and they will trouble you, but if you keep on chasing them, the best thing is to avoid them.
Yes, sir.
Don't look at them, just try to work somewhere else. In a short time it will disappear. So you see, I'm still expecting a lot of phlegm here in this lower part, because I can correlate from the MRI. 3 mm दे दो, RF दे दो जरा, 3 mm करेक्शन दे दो, RF दे दो, RF जरा. So you see, we still have to work little here to expose this more part of the ligament phlegm, because I cannot see the tip. So that was a tip of a superficial phlegm, not the deep phlegm. See them? Monday available fixation, sir. So you can see this phlegm is still having the good extension inside. Now I can
Yes.
see, now I can see the deep phlegm. Okay, and I have to still remove this tissue, this bone part in the lateral area, so I'll be able to see more of a. And see, don't pull out anything without confirming it. Okay, so you can see this is a big chunk of bone with the phlegm. Okay, so now so you see, the more severe and more tight is stenosis, there will be a more congestion. And in any of the endoscopic surgery, whether it's done for any other indication like ENT or laparoscopy or arthroscopy, if you have the bleeding, then you can't visualize anything. So like you have to be very careful. And any bony piece, you have to remove it. You just cannot say wet. So like, see, this is my picture as of now. So I'm just trying to get the hold of the view so I can work better. So I still want to remove this lateral part of the bone so I can expose more of the phlegm. Okay, so now you see, now I can see. Kishore, take the hook નથી લીધું આપણે. So you see, I have to detach this phlegm, then only I'll be able to give me ત્યાં સુધી કેરેશન આપ ત્યાં સુધી. So now you can see this phlegm is ending here. You can see the defect here. Okay, so now I will use the hook just to separate this phlegm. So now you can see, when I'm detaching the phlegm, now this has started pulsating. And let me just coagulate this with RF. So you can see now.
Yes, sir.
This is now pulsating.
Yes.
Like I just have to work and detach this more. So normally fat is not easily like you have to remove it with the forceps only. So I'm just trying to shrink it as much as I can, then I will start working. And then you see this all tissue. So like this all tissue, you have to shrink it to get the better visualization. Fine. Wait. Okay, now give me curate. So now you see, with the curate, I will just go here, I will just work here and I will detach it. Okay, so now we know that, okay, the whole the ligament of phlegm is coming out. Okay, because now there is no attachment here. So now I will go to the lateral side and I will just try to separate it from the lateral side. So now you can see that the root and dura.
Yes, sir. Dura is visible.
Okay, so like you see, when I am pushing it, there is no pressure on the dura, so I am safe. Okay, now give me comparison. So you see, now once you detach it completely, now you can safely remove it from wherever you want. So I do have the option here, go, take out, it will come out as a strips. Okay, and you can see how is the bad congestion. So you see, we are not like want to remove as an end block or something, because you see these are not the cases where your end point is a decompression. That's what you have to achieve it. That's all. And you see now, I'll just see. Okay, good. Okay, good. Okay. So you can see, I will just observe. Okay, fine. So you can see this is a big chunk. So you see, most important for me here is patient is awake. So when I touch any of the neural structure, patient will inform me. So that is the biggest safety. क्या हो रहा है? नहीं नहीं, कुछ है तो मुझे बताइए. हाँ, कुछ नहीं नहीं, you don't. आपको I'm telling the patient, we are keeping you awake for give us the feedback. Okay.
Yes.
So you are the part of the surgery, and then you see we can easily make you sleep. It's not difficult for us, but when you do it and awake, so we have the feedback from you, so we can prevent any complication. So you see, now I'm working on the lateral flavum. I'm deliberately not touching the this mid part of the flavum, because once I remove this one, then it will become more easy for me. Give me 4 millimeter. So now I am working on the lower flavum, lower lamina. So lower lamina, the flavum is just attached on the edge. So it's, you don't need to do the any boning work here. You can just, क्या बोल रहे हैं? गर्दन दिख रही है ना? कंफर्टेबल है ना? You are below the facet. SAP दिखाता हूँ बाद में. So now you see, I'm just going inside, and then we are just removing this part of the flavum nicely. नहीं नहीं, कॉन्ट्रैक्टर बाद में करेंगे. थोड़ा प्रेशर आएगा. हाँ, I'm just informing. So you can see the flavum here. कितना
Yes,
बड़ा है?
sir.
So this is all we are expecting, because this is the area where he is having the maximum pressure. और ये है ना, this is the SAP. So you need a very sturdy instruments also here, because you see that I am putting a lot of pressure on the instrument. Three. So you can see how severe is the congestion here.
Yes, sir.
Yeah, so now I'm going to use 2 millimeter kerosene and I'm just going to expose this whole area. So you see, I'm just trying to see that okay, I'm safe. Okay, I can see the dura inside. Okay, this is the dura inside. Yeah. इसके नीचे dura है ये. You see
जी.
here. When I remove this, then I will be able to see the dura. You see here, and you can see the dura inside.
Yes, sir.
So you can see this is what we are talking about. The congestion is more and more onto the lateral side. Midline is not that bad.
Yes, sir.
So like you see, this is the dura. Okay. Yeah, it's a part of the flavor.
Yes, sir.
You see, this is a part of the flavor. Okay. See, dura is quite deep inside usually. See, this is the flavor. So now I'm just trying to go more inside. You can see the dura here. So I will just catch hold of this phlegm here. So this is the midline phlegm.
Yes, sir.
You can see, and you can see the dura inside. Hmm? Yeah. Hmm. No, once I remove this, then you will be able to see the dura nicely. You can see the dura now.
Yes, sir.
You can see now the root is exposed.
Root. Yes.
So you can see the dura is quite safe here.
Yes, sir.
Okay. So you see these are all the like quite tight adhesions, and these adhesions are the responsible for patient symptom. क्या हुआ? गर्दन में दर्द है ना, दिस इज बिकॉज ऑफ फ्लूइड प्रेशर. वो बाद में थोड़ा कम करते हैं. See, Vedpal, this is I am talking about when he's
Yes,
awake.
sir.
Now he is telling us that neck में pain हो रहा है.
Hmm.
So this is the indication. So see, this is not like a easy case. This is a quite tight. And you always have eye on the dura here.
Yes, sir.
So now you see, now you will be able to see things are getting more and more free. But you can see this tissue here, but quite adherent. Now you see the dura.
Yes, sir.
अगर नेक का दर्द ज़्यादा हो जाए तो बताना है, तो हम थोड़ी देर वेट करेंगे तो चला जाएगा। हाँ, थोड़ी देर रुकते हैं, कोई बात नहीं। So you see, when he is having the more pressure, so we can wait, because you see now immediately after this he will be comfortable. अभी अभी पूछो उनको, थोड़ा 2 मिनट में ही कम हो जाएगा। अब अभी गर्दन थोड़ा कम हुआ, ठीक है, गुड, ठीक ठीक। So you see, this is my reason for local
Sir.
anesthesia,
Yes.
local anesthesia, because if the patient is under GA, patient has the symptoms, but it will mask. Patient will not be able to complain.
Yes, sir.
नहीं, हाइट बढ़ाएंगे तो ये नेक पेन ज़्यादा होगा। इनको अभी थोड़ा है ना अच्छे से 1-2 मिलीग्राम और मिडाजोलम दे के सुला दो, बिकॉज अभी क्या हमको फटाफट ख़त्म करना पड़ेगा। मे बी वी विल डू ओनली यूनिलेटरल, बायलेटरल नहीं करेंगे, बिकॉज बिकॉज यू सी दिस इज द इंडिकेशन, यू कैन नॉट गो अहेड। पेशेंट को कंप्लेन है तो ये एपिड्यूरल प्रेशर बढ़ रहा है, इसके लिए नेक प्रेशर हो रहा है, तो अभी ये दिस इज डायरेक्टली रिलेटेड टू द ब्रेन एडिमा। मेनिंजाइटिस में क्या होता है, नेक पेन होता है ना, तो ये सिमिलर यही सिचुएशन हो रही है। सो इफ़ यू जस्ट कीप ऑन डूइंग इट, सो नेक्स्ट स्टेप विल बी द कन्वर्जन, अगर इफ़ यू जस्ट डोंट डू दिस एनीथिंग। सो इवन व्हाट हैपन्स लाइक इफ़ यू टेक टू मच टाइम इन सर्जरी, so this complaint of the patient will be masked, and then you will see the post-operatively patient will not wake up nicely, so then you shift to the ICU next day and then नहीं नहीं, इसका प्रेशर नहीं है, प्रेशर ये जा रहा है, उसका प्रेशर है। अभी हम एक ही पॉइंट चलाएंगे। दिया मिला जुलम दिया, थोड़ा दो, अभी हम 15 मिनट में ख़त्म करते हैं। बस थोड़ा दे दो, जैसे ये से ओवर द टॉप बोलते हैं ना, ऐसे करो तो वहाँ पे तो आप ऑपोजिट साइड में हो। इनको 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 सुनो, इनको सुला रहे हैं तो इनको अभी डिस्टर्ब मत करो, बस ये ऑक्सीजन रखो नियर बाय, और बस चलो ठीक, ओके। एक चालू करो, कोई बात नहीं। एक इरिगेशन ऑन करो, कोई भी एक करो। नो, so you see the waiting in between the surgery, you will definitely lose your track, because you will always form a kind of a like some ooze clot, and then everything you have to find out. So that's why, like, I just want to start and continue and finish as fast as possible. Grasper there, and like you see, it's very risky to catch the clot with the grasper or something here. Okay, so now you can see this is a dura inside, and see what happens. You see the dura is here nicely. Okay, so what happens, because of the tissue will get the bloody tinge also, so you नहीं, आप हिलो मत, आप हिलो के नहीं चलेगा, और हमको बताए बगैर हिलोगे तो यहाँ पे प्रॉब्लम हो जाएगी। आपको कुछ भी करना है हमको बता के करना है। नेक में हो रहा है दर्द? कहाँ पे बोल रहे हैं? So that's why, like, see, sometime you are able to finish it completely. So that's why it's important to do it on the symptomatic side. At least you are able to. So I'm just trying to remove some here. So you can see the ligamentum flavum here on the lateral side. I'm just trying to. Now you are able to see the lateral margin is more clear.
Yes, sir.
Okay, so this is the lateral margin. This is also the part of the lamina. This is the bony canal. So you see, my entry was like this. Now I'm almost going like this.
Yes, sir. So you see, now our job is to remove this phlegm. Then we are done on one side. So we'll see if we are able to continue on the other side. It's okay. Otherwise, we'll finish, because you see, you should always be careful. The patient should be more comfortable, and we should not be able to give more complication. Okay. So you see, this is also from the lateral side. So this is the issue you find with the local anesthesia. But again, I'm very okay, because you see, to me, the patient safety is more important. And you can see we are able to nicely decompress the more and more ligamentum flavum in the lateral area. You can see. You can see how thick is ligamentum flavum here. Yes, sir. So you see my eye always on the dura. You can see the root is very clear.
Yes, sir. Underneath the ligamentum flavum.
Yeah. So like see, whatever you are pulling it out, you have to be very careful. You have to be very careful. So now you can see the root is more and more visible. So we are slowly we are able to remove the major part of the compression, and this is I am working on the foot end. Okay, so you can see this is the phlegm. You
Yes.
can see I am going inside, and see while I am pushing it, I have an eye on the dura that I am not pulling it. So again I will make a target. You can see the phlegm, the root is okay. So you see this is the biggest advantage, that you can work below the facet, and you can remove the this is SAP. मैं नीचे हूँ ना, नीचे SAP आएगा ना, IAP ऊपर. हाँ, I'm toward the foot end, yeah. So this is the SAP. This is the SAP. So if you are below the SAP, so your decompression is adequate. Like see, I'm removing this part of the phlegm along with the bone. You can see this one. So this is actual area you want to decompress. No. SAP. SAP में इतना कर लोगे तो more than enough है. So you see now I am able to see the root margin. So the
Yes,
root is finishing here, and now you see if I take this couple of bite here, so this is like having the big impact on patient outcome. You can see. So this tissue is actually inside, and I'm just try to remove. So the root is okay. This is addition now. Yeah. So you see the now is quite okay.
yes, sir.
So now is quite okay. So I'm just trying to take some of the compression here. So this area is quite difficult for anyone to work on the open surgery, because this is quite inside. So you see I'm removing the bone from here. So you can see this is additions because the root is in front of me. I'm okay with that. So again I go inside. This is the most crucial area over the root, where the root is becoming the exiting root. Okay. So you can see the root here is quite okay. So now I'm coming on the upper side. So you can see the root margin here also. So now I change my scope direction like this. So you can see this is the area
Yes, sir.
below the facet, and you can see the root here.
Yes, sir. It is well decompressed on ipsilateral side, sir.
Yeah, yes. So you see sometime like you may not be able to do the both side or something because patient is not comfortable or because of a lot of bleeding or something, but still like this decompression works for the contralateral side also. Now you see
Yes.
this is I am removing this phlegm from the gutter.
Yes, sir.
This is actually the lateral ligamentum phlegm on the side. You can see.
Yes, sir.
You can see this now. So this is on the edge. This is on the side of the phlegm, and now you see our root is
Root is free. Yes, sir.
completely free. Still, there are some tissues. I just want to work on this. So you see in chronic congestion there are some inflammatory membranes, like you see, you can see the complete root here. So there is some inflammatory membrane, so that is adherent, like that is between the dura and the phlegm. This
Oh.
inflammatory membrane will always cover your dura and you will have like a fear, but that is not a big job. You see this phlegm.
Yes, sir.
Now you see the root. You can see the root margin here.
Yes, sir.
It's very clear. Okay. So you see, this is our aim, to clear the root margin. So this camera is, so you can see the margin.
Yes, sir. Root margin we can see.
Okay. So this root
Yes.
margin is quite free. This is in the upper side. This is in the lower side. Let me just remove this tissue because this tissue is troubling me a lot. And now you see the root margin here also. Okay, so you can see the root margin on the both side, upper and lower below.
Yes, sir.
Yeah, no, not this one. इसको नहीं छेड़ेंगे अभी. Okay, give me this. This is the opposite side. आप जो बता रहे हो ना, this is the root margin. This is the facet here. So आप देख रहे हो यहाँ पे root margin is clear. So this is a perfect unilateral decompression. मैं just check कर रहा हूँ. I am not holding. तो root खींच नहीं रहा है तो I am okay. समझ रहे? If I am not pulling the root, it's okay. Okay, so now you can see the root is quite free. Okay, so I'm just showing you the original position. This is how we started. So this is upper lamina here. ये upper lamina यहाँ पे है.
Yes, sir.
Okay, this is a lateral area. 6 o'clock.
Yeah.
6 o'clock is a lateral area. This is all the inflammatory tissue, and this is the root free. Okay, let me just try to go more in, if I can go more in. अब देखो ये जो opposite side करना है ना, तो we have to go
Yes, sir.
and we have to remove this part of the ligamentum flavum. So this is opposite side. Okay. So I will, let me start it, but I will do it only if the patient is comfortable. Okay.
Yes, sir.
Dr. Anupam, मुझे भी यहाँ पे भी थोड़ा निकालना है, because you see, I see in the ipsilateral side, this particular area, there is still, I can feel there is still some small compression. So this is a SAP. This is a SAP, and see this is, yeah, this is, you have to remove it very carefully because you see the root is underneath. But you can see now there will be a big difference in the root decompression, because once you remove the SAP, the root is actually compressed in the lateral canal. So you can see now the root is free inside. दोनों चालू कर दो. अच्छा दूसरा भी लगा दो थोड़ा, चलो तो थोड़ा विजुलाइज कर लेते हैं। सो देखो हमने ऑलरेडी 60% जितना तो डिकम्प्रेशन कर दिया है।
Yes, sir.
ओके, बिकॉज इसी हमने मिडलाइन से भी थोड़ा डिकम्प्रेस कर दिया है। नाउ आई थिंक वी विल स्टॉप हियर बिकॉज दिस शुड गिव हिम सफिशिएंट रिलीफ। बाद में हुआ तो हम वो करेंगे, बिकॉज मुझे भी थोड़ा इधर भी काम करना है। यू कैन सी नाउ, नाउ दिस रूट इज गोइंग इनसाइड एप्सिलेटरल साइड पे, तो एप्सिलेटरल का अच्छे से काम खत्म कर देते हैं। यू कैन सी द नाइसली गोइंग।
Yes, sir. Nice decompressed roots.
हाँ लेकिन देखो यहाँ पे भी है ना, ओ ओ ओ ओ ओ, सो ही इज फीलिंग पेन। तो देखो ये काफ़ी अच्छे से डिकम्प्रेस हो चुका है। I'm just trying to pull out this one. So you can see this root is going inside.
Yes, sir.
Okay, and this is a soft tissue, so like there is no bony compression here.
No.
So I can accept this.
Yes, sir.
Let me still, मेरे को थोड़ा पता चलेगा when I'm touching he is able to respond. Wait. तो देखो ये जो है ना,
Hmm.
या ये रूट है, ये कोड है, तो हम अभी एक साइड पे हैं। देखो ये रूट है, तो ये और अंदर जो देख रहे हैं ना, यू कैन सी नाउ दिस इज द एक्सिला एंड दिस इज द शोल्डर। थोड़ा यहाँ पे फ्लेवम है, आई विल ट्राई।
Yes, sir.
चलेगा है। So you see the important lesson is here is also when you want to do it, and suppose if you are not able to complete it, so not to do the complication, because you see that's why we started from the symptomatic side.
Yes, sir.
And so at least we will be able to tell that okay एक साइड का हो गया, एक साइड का बाकी है, because you see suppose if you are not able to finish it and then if you end up with a complication, the entire picture will change. At least ये एक साइड का जो कंप्लेन है ना वो तो विजिबल होगा। एंड आई वांट टू रिमूव दिस फ्लेवम बिकॉज दिस इज, नहीं आप हिलो मत। ये तो हमको निकालना पड़ेगा।
Fluid related.
क्या हुआ?
House is asking that what complications we are looking for, like fluid related complications, sir.
Yeah, fluid related complication, and you see these are most serious, these are not top.
Yes. Yes, sir.
And people are even not aware also. So ये अभी है ना, you see this root and this particular ligamentum flavum यहाँ पे, so इतना निकाल लेते हैं, so at least it will make the complete this one free, because you see patient is constantly complain about the headache. Okay, so we stop one times. Now if I stop again, then this oozing will not let me finish my work. So then you see putting the camera second time, it's such a dangerous thing for us, because you see you don't have a orientation, you don't have idea about the depth, and everything is like this in trouble. So like see this is Kishore, 4 millimeter आप जाना. So I'm just trying to remove this lower phlegm as much as possible, and see sometime what I do, I just break the opposite side ligamentum phlegm.
Yes, sir.
I break from the center, so now this tenting effect will be down, because I say that the spinal stenosis is like a compartment syndrome. So your compartment, if you just break the whole of the roof of the ceiling, then still there is no active compression, and still the patient will do well. So you see, this is already we are on the opposite side.
Yes, sir.
This the bone which we are seeing, the opposite side bone. So you see, this is also a big safety for me because patient is responding. So ये opposite side का है phlegm. So I'm going there and I'm just detaching it. This is opposite phlegm. Okay. So now we will be able to थोड़ा पता चलेगा, थोड़ा पता चलेगा. Now you will be able to see the complete code.
Yes, sir.
You see my hand movement and my scope movement.
Yes, sir.
तो मैं ये ऑपोजिट साइड में हूँ, तो ये ऑपोजिट साइड का भी हमने काफ़ी निकाल दिया है.
Yes, sir.
Okay. So you can see the amount of congestion also there. बहुत congestion है ना. So if I am able to remove this small portion, तो हमारा ऑपोजिट साइड भी decompression complete हो गया. Okay, I think we are lucky.
Yes, sir.
So अभी देखो मैं आपको I'll show you the complete code. थोड़ा पता चलेगा. ये देखो, ये ऑपोजिट साइड कोड का मार्जिन है. You can see. Okay. Now you see, if I still want to continue it, I can do this. I can remove this ligament of phlegm.
Only in the lateral recess, sir.
हाँ, ये opposite side lateral recess है. So
Yes,
let
yes.
me just
Yeah.
decompress this.
This is sufficient then. Yeah.
हाँ हाँ, देखो ये है ना. So I break most of my scopes here because I put a lot of traction to hold this. So ठीक है. देखो,
Yes, sir.
तो अभी पूरा ये कोड दिख रहा है, ये पूरा दिख रहा है.
Yes. Full decompression is done.
ठीक है. तो आई थिंक
Yes, sir. Yes, sir.
थोड़ा भी ज़्यादा लालची नहीं होंगे. डॉक्टर अनुपम इज सेइंग मोर देन सफिशिएंट.
नहीं, okay.
नहीं ठीक है. देखो यहाँ पे थोड़ा है ना, ये कट लेते हैं. नहीं ठीक है. चलो. So Dr. Anupam is little worried, but you see now I can show you the entire code. So देखो ये पूरा कोड दिख रहा है, दोनों मार्जिन दिख रहे हैं. ओके, एंड द कोड इज नाइसली पल्सेटाइल. ठीक है.
Nicely pulsating. Yes, sir.
चलो ओके, चलो अभी ड्रेन दे दो, हमारा काम हो गया. अब हम आराम से
पूरा कॉर्ड है.
ठीक है. ये थोड़ा निकलना तो निकल सकते हैं, लेकिन अभी छोड़ो. चलो निकलना है. चलो ला दे दो. अभी आप मुझे 2 मिलीमीटर दे. हाँ नहीं ठीक है, निकाल देते.
हाँ, कर तो दिया. प्रोजेक्ट साइड हो गया. नहीं कर.
2 मिलीमीटर.
ये लो स्ट्रिंग बची है.
चलो ठीक है, मिनट में
हो गया.
क्योंकि ये आपके ब्रदर है ना. हाँ ब्रदर है ना, वही पूछ रहा हूँ. तो क्या सर के ब्रदर है, इसके लिए थोड़ा सर वो कर रहे हैं. तो ठीक है, कोई बात नहीं. हाँ
हाँ थोड़ा और चलेगा ना, ठीक है चलो 5 to 10 मिनट। देखो इसको कैसे निकालते हैं, आई शो यू। देखो ये लेटरल मार्जिन है ना, इसको ऐसे पकड़ लेने का,
Yes, sir.
और है ना यू पुट द कैरिसन लाइक दिस, यहाँ से आएगा कैरिसन, ये है ना इसके अंदर जाएगा, तो ये थोड़ा बोनी डिकम्प्रेशन भी हो जाएगा। एंड इसको स्कोप को थोड़ा घुमा देंगे तो हमको दिखेगा। नहीं उससे अगर ज़्यादा वो बड़ा होगा ना तो क्या होगा, नहीं कैरिसन का जो बड़ा हो जाएगा ना, देखो ये बड़ा हो जाएगा, जितना ये होगा इतना उसको नीचे डालने के लिए तो वो आपके हाथ में ही नहीं आएगा। सो नाउ लेट मी जस्ट सी दिस। तो देखो ये मार्जिन तो काफ़ी क्लियर है, चलो छोड़ो छोड़ो छोड़ो, चलो ठीक है चलो ओके, बिकॉज चलो ठीक है ठीक, चलो ये तो मस्त है, कोई प्रॉब्लम नहीं, चलो फाइन। सो यू कैन सी नाउ, यू कैन सी द
Yes, sir.
कंप्लीट पल्सेटाइल को। देखो ये इतना पल्सेटाइल कर रहा है और मुझे कहीं पे किंक नहीं दिख रहा है। सो इफ देयर इज नो किंकिंग यू आर डन। चलो
Yes, sir.
और ये साइड में रख देने का। और सबसे बड़ी मज़ा देखो, लाइक सी दोस हु आर ऑर्थोपेडिक न्यूरोसर्जन, तो आपको अभी पेशेंट से बात करने की। अंकल जी ठीक है, जोर से बताओ, यहाँ पे सुनाई नहीं दे रहा। नो प्रॉब्लम, ओके। एंड लाइक सी यू कैन ऑल्सो सी द पेशेंट कैन ऑल्सो, अभी इनसे मैं पूछ भी सकता हूँ, थोड़ा ये पैर ऊपर करो, थोड़ा दोनों पैर ऊपर करो, ओके वेरी गुड। ये राइट वाला ये लेफ्ट वाला, ओके। डॉक्टर वेदपाल कैन यू सी दिस?
Yes, sir. Yes, sir. Very well.
देखो ये मैं ये सब बोलता हूँ, ये पेशेंट से ज़्यादा अपने लिए पीस ऑफ माइंड है, ठीक है। वो बाद में जाके वो क्या, लाइक सपोज इफ पेशेंट इज हैविंग वीकनेस आफ्टर द सर्जरी, so it's very difficult to explain the relatives, very difficult to explain, क्या जवाब देना ना वही पता नहीं चलेगा।
Yes, sir.
and then you have to create a story कि थोड़ा दिन में हो जाएगा, 4 दिन में हो जाएगा, 5 दिन में हो जाएगा, और रात को खुद को नींद नहीं आएगी, वो भी सही है। और अगर पेशेंट थोड़ा वीआईपी हुआ तो फिर कोर्ट के चक्कर भी चालू हो जाएंगे। सो यू सी दिस इज व्हाट लाइक आई ऑलवेज से, दिस इज गुड फॉर अस, अपने लिए है। थोड़ा देखो हाँ हो गए, थोड़ा पेशेंट को थोड़ा तकलीफ पड़ा, ये पड़ा चलता है, लेकिन है ना वो पेशेंट की सेफ्टी के लिए है। 2 बार ऐसा हुआ कि मैंने कुछ टच किया देन ही से तो मैं रुक गया, अदरवाइज आई वुड हैव स्ट्रिप द ड्यूरा एंड आई वुड हैव कम आउट।
Yes, sir.
पेन नहीं हुआ ना आपको ज़्यादा? ठीक है चलो, पेशेंट इज ऑल्सो वेरी हैप्पी, पेशेंट इज वेरी कोऑपरेटिव, but you see like this is a peace of mind. I always say this is a peace of mind for everyone, not only for the surgeon, for the patient, relatives। ये अभी इनको 2 घंटे में आराम से चाय पानी पिलाओ, बाथरूम जाना है तो खुद जाओ, और 4 घंटे के बाद इफ ही इज कंफर्टेबल ही कैन वॉक। एक मिनट आता ना, ट्राई कर ले। चल और वेदपाल, आई ऑलवेज लाइक टू पुट दिस ड्रेन
Yes, sir. Yes, sir.
and you always make sure that the drain should ooze something, so it means your drain
Yes,
is
sir.
not misplaced।
Yeah, patency is important.
या तो क्या होगा, कई बार ये बाहर आ जाता है, देन लाइक द पर्पस इज नॉट सर्व। सो जब तब तक तुम ये स्टिच लेते हो तब तक ये ड्रेन होना चाहिए। और उसका
Yes, sir.
एडवांटेज भी ये है कि लाइक इट विल रिमूव द 2, 3, 4 ml, 5 ml, 10 ml अप टू ब्लड निकाल दिया, तो पेशेंट का जो ब्लड का जो रूट पे इरिटेशन होगा वो नहीं होगा।
Hematoma नहीं बनेगा, हाँ जी सर।
हाँ और क्या हिमेटोमा की वजह से कुछ भी हो सकता है, तो ये
हाँ।
मोस्टली माय प्रोटोकॉल इज द नेक्स्ट डे मॉर्निंग और मे बी आफ्टर 4-6 hours, if
Yes, sir.
it is not draining more than 20 ml, I will remove it।
Remove it, yes sir.
और and we are putting a mini bag, तो ये बहुत छोटा सा है, अगर इसके साथ भी पेशेंट को चलाना है तो भी आप
जी।
चला सकते हैं। ओके
Yes sir.
so I think this was more of convincing।
Thank you so much sir. What a wonderful presentation.
Thank you।
Nicely done. Bilateral decompression. House is very
थैंक यू वेरी मच।
Thank you so much, sir. Thank you so much.
थैंक यू, बाय। बंद करो। हाँ उसी से कल तो निकाल देना, 4 घंटे 6 घंटे रहेगा, 8 घंटे रहेगा, ट्रैक कहाँ से बनेगा? ये ऑलरेडी तुम्हारे पास जगह है तो उसमें से करो ना, एक नया इंसिजन डालने की जरूरत नहीं है। मोस्ट ऑफ द टाइम इफ ये 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 मेरा स्पेशल स्कोप है, बहुत छोटा है, 100 मिलीमीटर का है ये। और इसके रिलेटेड मैंने इंस्ट्रूमेंट भी छोटे बनाए, तो एक बड़े इंस्ट्रूमेंट होते हैं ना, तो तुमको ऐसे करना पड़ता है, ऊपर चढ़ के करना पड़ता है, सो यू आर नॉट कंफर्टेबल। हियर यू आर कंफर्टेबल। ड्रिल ये जो नोवा की है, ये ड्रिल सबसे इम्पोर्टेंट है। और ये ड्रिल है ना, एक ड्रिल 50 केस में चलती है, 50 केस में आपको यूज़ करते हैं। अभी आप ऐसे करके ऐसे करोगे तो टूटेगी, लेकिन जितना आपको बोन, इसको कैरिसन बोन कटर, वो 90-20 डिग्री का कोई मतलब नहीं है। ये स्विस कंपनी नोवा करके, ये स्पाइन ड्रिल ही है। हाँ कॉस्टली। देखो आप कोई रिलेवेंट क्वेश्चन ही नहीं कर रहे हो। दिस इज नॉट रिलेवेंट। तुम ये बोल रहे हो कि स्विट्जरलैंड बहुत सुंदर है, बराबर? तो स्विट्जरलैंड सुंदर है ही, लेकिन अभी तुम यहाँ पे कश्मीर में हो, तो कश्मीर के बारे में बात करो ना। तो इंटरलेमिनर एंडोस्कोपिक पूरा अलग चीज़ है, इंडिकेशन अलग है, काम अलग है, इंस्ट्रूमेंट अलग है, सब कुछ अलग है। तो ये दोनों का कोई वो भी नहीं है। जिसको इंटरलेमिनर करना है उसको इंटरलेमिनर करना है, जिसको ट्रांसफर्मल करना है उसको ट्रांसफर्मल करना है। हो जाए तो हो जाए, उसके लिए प्लान भी तो चाहिए ना। कुछ भी हो सकता है। अभी यहाँ पे एनेस्थेटिस है, उसका लिए सिंपल आंसर ये है कि ये आप ऑपरेट करते हो, ईसीजी लगाया, एक्सरे लगाया, ऑक्सीजन लगाया, यहाँ पे एनेस्थेसिया की किट है कि नहीं, इंट्यूबेशन करना है तो है कि नहीं, यानी तो एनेस्थेसिया में सपोज के पहला रूल क्या है, अगर पेशेंट को स्पाइनल देना है, पेशेंट को अगर शॉर्ट जीए देना है, व्हाट इज़ द फर्स्ट रूल? बैकअप जीए अवेलेबल होना चाहिए ना, ऑक्सीजन अवेलेबल होना चाहिए ना। तो देखो ये है ना, कोई शॉर्टकट है ही नहीं। एंड शॉर्टकट अगर सोचो तो जो कर रहे हो वही करो। अगर तुमको युद्ध लड़ने जा रहे हो और तुम बोलो मैं लाठी से जाके लड़ूंगा, तो घर पे बैठो। ये कोई चॉइस, मैं वही बता रहा हूँ, कोई न्यूरोसर्जन है, उसको ट्यूमर करना है, माइक्रोस्कोप चाहिए ही चाहिए। अब वो अगर उसमें उसने गड़बड़ी की और नहीं किया और बोला कि नहीं मैं थोड़ा देख लूंगा कर लूंगा, तो वाई यू वांट टू पुट द लाइफ ऑफ द पेशेंट। पेशेंट तुमको बोल ही नहीं रहा कि साहब आप ही दुनिया में अकेले आदमी हो, मेरी सर्जरी करोगे, भेज दो इसको कि भाई मेरे पास इक्विपमेंट नहीं है, ये करेंगे। लेकिन है ना, जब ये अवेलेबिलिटी हो, जब सब हो, तब भी काम करने का। अदरवाइज रिजल्ट कॉम्प्रोमाइज है ना, आपकी इंस्ट्रूमेंट की इनकेपेसिटी की वजह से ही इनिशियली होंगे। देखो ये मैं कितने कंडीशन लेके बैठा हूँ, 1 2 3 4, ठीक है, यहाँ पे भी 1-2 पड़े होंगे, यानी सब लेके मैं बैठा हूँ। मेरे पास ये पता है कि राउंड शाफ्ट कंडीशन अलग है, ये दूसरा ओवल कंडीशन अलग है। राउंड शाफ्ट जब मैं डालूंगा ना तो ब्लीडिंग बंद हो जाएगा, समझ रहे हो? तो वो सारी चीज़ें हैं, वो इम्पोर्टेंट है। तो मेरे लिए मैं इसको भी लेके आया, मैंने बोला कि नहीं तू आ जा, सबको बोलेगा नहीं आएगा, क्योंकि मुझे यहाँ पे भी मुझे कंफर्ट चाहिए ना। तो मेरा रिजल्ट मैं अपने कंफर्ट पे दे पाऊंगा। इफ सपोज ये भी नहीं है, तो अभी ये ड्रिल है, चला नहीं चला, ये हो गया, तो कौन देखेगा? तो देखो एक है ना, ये एक रॉकेट साइंस है, तो उसको रॉकेट साइंस की तरह ही उसको रखो। कॉम्प्रोमाइज़ करो, ये शेवर वाले ड्रिल, उसका क्या बोलते हैं, उसका ड्रिल यूज़ करो, शेवर ड्रिल यूज़ करो, कोई मतलब ही नहीं है। तुमको एज नहीं मिल रही, तो तुम यहाँ से कैसे चालू कर सकते हो? तो और बाद में करो, अभी नहीं है तो। लेकिन देखो आप समझो कि जब तुमको तुम्हारी फैमिली में तुम्हारा कोई भी मेंबर है और तुमको पता चला कि हॉस्पिटल डजंट हैव दैट इनफ सेफ्टी मेजर्स, और पेशेंट लापरवाही से उसका कुछ प्रॉब्लम हुआ, तुम उसको माफ़ करोगे हॉस्पिटल को? तो सिमिलर ये है ना कि पेशेंट तुम्हारे विश्वास पे है,
पेशेंट हैज ए ट्रस्ट ऑन यू कि नहीं आप डॉक्टर साहब आप चाय तो पियेंगे सर, चाय तो पियेंगे, चलो। तो ये है ना, ये थॉट प्रोसेस ही गलत है। शॉर्टकट ये नहीं होता। ये आधे लोग उसमें, एक पेशेंट का गड़बड़ हुआ ना, एक पेशेंट का कैरियर तुम्हारा चौपट चौपट, भूल जाओ। यही तुमको कंप्लेन होगा, पूरे मार्केट में पता चलेगा, अगर न्यूज़पेपर में आए, और तुमको उसका जो एल्यूमिनी देना पड़ेगा ना, वो इससे 10 टाइम्स 50 टाइम्स 100 टाइम्स ज़्यादा होगा। अभी तो 10 20 25 करोड़ से नीचे तो कोई बात ही नहीं करेगा। और पता है इसका कंपनसेशन कैसे कैलकुलेट होता है? एज, मंथली सैलरी into the expected years patient is going to survive, गिनते जाओ। देखो इंश्योरेंस है ना, इंश्योरेंस इंडेमनिटी इंश्योरेंस है ना, मेडिकल नेग्लिजेंस पे नहीं अप्लाई होगा, कॉम्प्लिकेशन पे अप्लाई होगा। तुम सोचो कि अगर तुम यहाँ पे है, ऑक्सीजन नहीं है और पेशेंट लुढ़क गया और साबित हो गया कि ऑक्सीजन नहीं है, तो मेडिकल इंडेमनिटी क्या इस पे तुमको माफ़ करेगा? कभी नहीं माफ़ करेगा। सो मेडिकल कॉम्प्लिकेशन पे, जो डॉक्यूमेंटेड कॉम्प्लिकेशन पे, ये नेग्लिजेंस इज ए टोटली डिफरेंट बॉल गेम। नेग्लिजेंस क्या है?